All right, thanks for coming, everyone. This is our critical appraisal seminars in anesthesiology research. So that's a Journal Club reimagined. So just the learning objectives we want to go over today. To recap what we've done so far this year, I know not everyone's been here for everyone. We're going to repeat, but we've done randomized controlled trial. We've done some PK/PD studies. We've done retrospective studies. One thing we haven't looked at are sort of these more zoomed out, overarching studies, and that includes meta-analyses and guidelines. So it's sort of an amalgamation of different studies to get at the same question. So it's a type of research study that you'll run into pretty frequently. It's considered very high-level evidence, or at least uses what should be the best available evidence if it goes into a guideline or a practice statement. So we're going to critically evaluate a meta-analysis that we sent out before, consider study heterogeneity, learn how to interpret a forest plot, and discuss bias in meta-analyses and how that can come about and how you can try and control for that. And look at guidelines for generating a meta-analysis. So that's what the handout is here. So that's sort of the consensus statement on what should be in a meta-analysis. And then look at the advantages and limitations of guidelines and meta-analyses. So looking at when you should apply them, when they work, when they fail, what they're good for. So do you want to go over this one that you sent out?
Oh, sure. So I thought since Nate came to me and said we should do a meta-analysis, and it turned out that the current was 2 days ago current. Now there's April edition is out of Anesthesiology, had a nice article in there by Jeff Applebaum, who was actually a medical school classmate of mine, but he kind of put together the, I forget the name of the group that they put together for critical assessments at the ASA. So the ASA was one of the very first groups, professional societies, to respond to the NIH to systematize their way of putting out guidelines. There had been a lot of consensus statements before that. We were seen as a leader in patient safety for many years, and they put out a request to let's make this more scientific and more rigorous. And Jeff had been kind of instrumental from the beginning in that for two reasons. One is he's an academic. He's been in academia his whole career. He was chair at the University of Chicago. He was also in the leadership, what do you want to call it? Staircase, runway, whatever. He was a president of the ASA at one time, so it takes a long time to get in that pipeline. And then he was, and as an ex-president, you kind of stay in the leadership. So he's really been instrumental in making this happen. It also was advantageous. I was just talking to Nate about it, in that one of the things if you've read this, he talks about the kind of the structure that they undertook, and one of them was to have a non-clinician PhD who is a statistician kind of lead the charge and make sure they stayed on track no matter who was put on the panel for a particular guideline. And the fact that Jeff lives in Chicago and the ASA is headquartered there. In fact, they're in the northwest suburbs, which is actually where Jeff lives. So it's actually more convenient for him to go to the ASA than to go down to the south side of Chicago. But this is a very good article. And I think Nate is going to touch on, because the article touches on how do you assess bias, how do you do all these things, and then how does the ASA work in sometimes a data poor environment when all you really have is surveys, because that's always their last step. They go out and they do everything right. They get Class A1 data, if they have it, they form what they think should be evidence-based guidelines. Then, because it's a political process, they take it to the ASA and they ask experts, which I think he delineates in there somewhere between 50 and 100, 250, depending on the subject matter. And then it goes out to randomly selected practitioners, whoever's in the ASA. So you may be called on someday, whether you become an expert or whether you're just in private practice, but they just want to see how many of these things are reasonable, do they think will actually happen, and then they adjust. So it's based partly on science and partly on consensus.
And one point on that. So if you're going to put a guideline together, what are the pros and cons of this approach? So there's two parts. You mentioned that the key things are what studies are available, but there's this last piece, right? And there's a whole field called implementation, and I think it gets at some of that. What are some of the problems you've run into when you're in the OR, you have a question, we've brought it up with different study types. How does it apply to guidelines? Is there a guideline for everything? So why do you need both approaches, right? Like Jake.
Well, you need to be able to utilize the information from the guideline to the specific situation that you're dealing with. Everything's not cookie cutter. So having some clinical judgment mixed with the data.
Right, and are guidelines static documents? Are we still working with like the 1970? Right, so things change. Not everything is easy to study with either an RCT or some of these other techniques. Right, so you want to make sure that what's done is rigorous, but there may not be enough studies to inform practice at that point. Then you need to go to people who are in the OR working all the time to get some sort of consensus, and it may not necessarily be scientifically based, but it's based on clinical practice and sort of practice parameters, which I think that's where the survey method comes in.
Right. And as I think the article points out, is two of anesthesiologists' greatest hits, top 10 cited ones have been ASA guidelines. So the one that sticks in my mind, because I got to see it kind of put together, was the difficult airway one that came out in 2002, which was led by Andy Olasapien. That was that's one of the greatest hits, is the algorithm for, trying to avoid the can't ventilate, can't intubate corner. And that was, and how to avoid that was a guideline that was put out. It was one of their first ones, and as it turned out, it became very well known. And just to point out here, this is kind of the ones where they've collaborated. So this is in Jeff's article, talking about how often it's done in conjunction with other societies, and they bring them in as they can. If those of you who were at Grand Rounds on Monday will recognize this last advisory that came out on visual loss that was discussed at length on Monday. And a part of what's in a couple of these is capnography. So 2017, there have been a couple on moderate sedation and different kinds of sedation outside of the OR that have talked about capnography, and when it's gone out as a recommendation, to the society, it ended up not passing muster for evidence reasons and practicality reasons, that not every sedating location should be expected to have capnography. So it's a recommendation, moderate, but it's not mandatory. Pulse oximetry, there were no dissenters anywhere on pulse oximetry. So that one got in, it's mandatory, and I think every place that does sedation has it. because the ASA and other societies have said that, but we haven't had overwhelming evidence on capnography yet.
So can you think of what implications this might have outside of your individual OR? So just to compare and contrast, you've got pulse oximetry as a standard of care in the guidelines, capnography plus or minus. Now you've got a community hospital, maybe you're the CEO, right? You want to run procedures. It could be a large financial burden where they have to weigh patient safety, what is standard practice, and sort of what goes into that. So if they mandate that, it then can have big implications. A similar topic is the procedural sedation and who can do that and what levels of sedation, because there's GI docs sometimes will push to do their own sedation because then all the reimbursement goes there. So if there's a guideline that goes against it or extends past the evidence, you can have major financial ramifications in addition to patient safety. There's a lot of moving parts with it, which may play into some of what's going on with capnography.
Yeah. And we'll get into when we look at this meta-analysis, but just to give you a flavor of where these things are, I like to take the cynic's point of view because I'm old enough that nobody can hurt me anymore. I like being the cynic. But I was asked to come be an expert at a GI Grand Rounds, and where they had an ED incident. Interestingly, they didn't have an ED doc. It turned out the ED doc did everything exactly the way we would have, but the GI docs were pissed off that A, he used capnography, and B, he intervened and stopped their procedure when the patient was at it. And then why the hell, our literature says you don't need capnography. So that's interesting. I found that very interesting, and something that really kind of tickled my cynic bone. My patient did well, by the way, but they were still upset. So there can be a bias to minimize these things for reasons you would never think of.
Right. So point being, it's important to know who weighs in on guidelines and why.
Yep. Okay. Want to take over?
Okay. All right. So
I would encourage you to take a look at that because it really gives you the nuts and bolts of how these advisory, and they also gave a schedule of when some of these are going to be reviewed. So the sedation one is being reviewed now for a 2020 update. And it was in this article telling you to keep an eye out so that they're looking for new data, new studies to update. So these aren't static. Once done, they stay the same way forever.
okay. So the article we're reviewing is that meta-analysis that we sent out. There were two, right? We went over just sort of the overview. Before we get into the specific paper that you read, I wanted to bring up this PRISMA statement, which set the standard, sort of the guidelines on meta-analyses. And it's the accepted format to follow. And there's a checklist that I passed around. So a way to assess how well they adhere to these guidelines and what should be there to be a rigorous meta-analysis.
Is that Altman and Bland Altman?
Might be. And so this is what it stands for: is preferred reporting item and items for systematic reviews and meta-analyses. And so here's your flow of information, because what you're trying to do with a meta-analysis is take a lot of different studies on a related topic and pool them to get better statistical power and try and draw conclusions. Because randomized controlled trials do not happen on lab rats. It happens in varying degrees of real-world situations with real patients. So you can get different answers. So depending on how well-powered it is, what's going on with the population, there can be this natural dispersion within it. So meta-analysis is a way to combine these, compare them, or contrast, and sort of increase the power of the available studies. So this is the flow of information that the way that goes through. So does someone want to take us through this, or how do you think you would need to do this? Where would you even start?
Appreciate your question, I guess.
Yeah.
And then start searching the, public literature databases for what's already been found on, that topic. Whether it's controversial or not, I guess.
Right. So that's step one. There's one piece though this is the first source of bias. One, you can design your question a certain way. The second is there's publication bias. It's pretty difficult to get a negative study published, especially in a very visible journal. So this used to happen all the time prior to clinicaltrials.gov and mandating of reporting of trials. If you're a big pharma company and you've dropped $100 million on your drug development, you just do 6 studies and bury 4 of them, and you publish the 2 good ones. So part of the meta-analysis is trying to get beyond just the publication. So they'll scour abstract. If there's publicly available abstracts, or if they know someone's working on it, they'll send out emails and they'll include this in their methods. So that way you can try and counteract some of this publication bias. It's a little better now with having to register clinical trials ahead of time, but it can be a pretty substantial effect on your question for that reason, for being able to bury studies, and also who paid for them. Also determines what questions they asked. All right, so now you've gathered all the available literature. You called everyone who's ever heard of your topic to see if they have any buried studies, see if they'll share it with you. You document all of that. What do you do next?
Decide which studies to include based on some criteria that you set.
And do you do it alone, or
Do what?
do you do it alone?
No.
There's usually there's almost a committee level, right? So this could be another source of bias. You say, well, I don't like this one, or right, there could be either like a personal bias, there shouldn't be, but depending on who's putting the meta-analysis together, there can be other reasons you include or don't include different studies. So you gotta agree. So is there anything on the Prisma statement that helps get us on this?
Eligibility criteria?
So that could be on the subject, so that's on the studies themselves, right? But it's also on the subjects who participate in it. So you want to make sure you're comparing similar things. So in quite a few meta-analyses I've read on more obscure topics, outcome variables can be really different. So let's say you're doing a pain study. What are the different ways you can look at pain? You've got visual analog, you've got the tick mark, you've got happy faces, you've got opioid sparing, there's a representation of the emergency department. So deciding how you can compare those. What if there's no control group? Can you put that in with other studies that have a control group? You can see it gets pretty complicated pretty quickly. You want to acknowledge that the study was done on the topic, but it could be really poor quality. So there's a way to assess, to grade the level of evidence within the meta-analysis. And that goes into the summary statement. Okay, so you search the database. That's part of the qualitative, right? The qualitative step of that is where the studies fall on the levels of evidence, what the issues are, whether there's bias inherent in that. And so then you decide what to include, what you can combine. Okay, so this is our checklist, and it goes pretty much in order. Let's see. Was anyone assigned for methods? Did we get we didn't get the assignments out? Okay, yeah, it was kind of late. Sorry, guys. All right, so we'll use this to go through. This is the article that was sent out. So with that in mind, let's go through the checklist and see if they adhere to it, what some of the issues are. and in light of all that. So what is this?
It's a Prisma diagram.
Right. So they started following the guidelines, right? So what information do we get out of that?
You get a lot of the information from the methods section, and it also tells you what parts of the Prisma checklist they adhere to.
Mm-hmm.
So the amount of reports that they identified from their literature search, how many were duplicates, how many they excluded, and then the amount of trials they ultimately ended up including.
So at the top, we're starting at 547. Came up in the PubMed search, or what are we left with?
It's amazing how many were duplicates.
Yeah.
Over half.
Yeah. Maybe, I don't know if that's double publication or if it just came up in the mesh headings or, but yeah, so
Yeah.
you can start with a big question, but there's not everything, you can't combine all of them. Okay. So then what is this a summary of?
8 studies.
Yeah. But it's not so much the numbers, right? This is the qualitative analysis, right? So you need to know how many patients are in each study, who did they study, right? Can you compare them? Is it some of it will be pediatrics? Maybe it's identical study, but it's everyone under 18 or everyone with maybe it's capnography and people post lung transplant. It's going to be completely different than your GI capnography for a colonoscopy or something, right? So those you probably couldn't combine and you wouldn't have the same outcome variables or the same issues. So this is just describing what they picked, why, and why they thought it could be included. So what were the other things that we needed to know in order to do a meta-analysis? So you've got the input and the output, right? What are the two sides of that? So we talked about one, it's subjects. But the big thing with randomized control trials, everything is outcomes, right? What do you actually measure? How do you know what you're measuring and what happened? So this is table 1. They describe those 8 that made the cut. So what are we looking at now?
That's a forest plot.
What is a forest plot?
This just basically shows your odds ratio and then where each study falls there, and then it does essentially like a composite analysis of all those data at the bottom and shows if there's a difference or not.
And so what are the big landmarks on here that's worth paying attention to? If you know nothing about the statistics or anything that's going on, what is just, you can glance at this and what does it tell you?
But there is a difference, it looks like.
Yeah. So what you want to look for is whether it crosses 1. So looking at that 95% confidence interval, whether it includes equivalence, gives you a good indication of whether that was significant. What about the size of the boxes? What is that? What are the boxes and lines telling you?
Sample size and standard deviation.
Yep. So you can see that those sort of go together. Tiny box, big line, right? So there's a big dispersion in the data. But you'll see this when you look at meta-analyses. Sometimes there's one giant study that they did, right? And that will completely sway. Even if you have 10 other smaller studies, they could have been pilots leading up to that. And so maybe 90% of what you're seeing is just driven by this one large study. But if that one large study is wrong, which can happen, then it can make it into the guidelines, or you can have major issues, even if 15 other studies are going in the other direction. But you can see the variability within that. But by including them in the same analysis, you can narrow that variability and get a more conclusive answer. So that's some of the power of what you can do with meta-analyses. So what this one is looking at, so this is during GI procedures. Okay, so another forest plot. So what What's the conclusion we can get from this one?
The only thing the GI docs would look at is the second to last study.
Right. You can cherry pick your answer. You get the right one. Yeah.
Just like on aggregate, there's a lower odds ratio for severe hypoxemic events.
Right. Taken individually, though, none of those studies are particularly compelling. Right? Some of them aren't significant. One is in the opposite direction, as you pointed out. But you can narrow out some of that dispersion in the data by including them together. What about this one? So this is just looking at apnea incidence. So this one was not significant, right? So the studies were all over the place. They don't come to a conclusive answer with that. So there's either not enough data, the studies are too small, or the spread is too large to draw any conclusion from that. What about this one? Right. So one thing we're going to talk about, let's compare each of these. So I want to draw your attention to that I squared value. So this first look at what the size of the box is, dispersion in the data, and sort of the conclusion. But the next thing is looking at that heterogeneity statistic. So this is a way to quantify how different the studies are, and what this is it's a measure of the variability due to study design that gets into the meta-analysis. So you really need those two pieces of information to see what was going on. And if you look, it can go with the results, right? So we've got an I-squared of 43% in this figure. If you look at the next one, pretty similar, 53%. You've got the similar size diamond there. So we've got more confidence. Now, as the studies get more different, you see you have more dispersion, you can't come to a conclusion. And then this one has the lowest I-squared. So it's another metric of what's going on in the data. You can objectively tell whether a meta-analysis is even appropriate for this question, right? It can give you an indication of whether there's enough done about it to be able to tell what's going on. Okay. Thoughts? Questions about meta-analyses?
A couple. Go back to, they said their primary one was that first forest plot, right?
Yeah, so this is the...
So, and I didn't have time. Did you look at their funnel plots or think about those? Because they said it was in supplemental.
Yeah.
And there were a couple of things that were kind of glaring to me. One was, I didn't look at the funnel plot, so I don't. You might know what that is. So it's basically a triangle. So at the very top, there should be a little bit of variability in what the studies find, because those were the big studies. And then at the bottom, there could be variability on both sides, and they should be spread out evenly. And those are the small studies. So if there's a bias, you're not going to have a triangle. You're going to have, like, all the small studies are over there. And, we kind of have, it's not entirely that way, but it's interesting because first of all, this was only about endoscopy. So it's not really about capnography. This was capnography married with endoscopy, which is how we got to just 8 studies. The big studies were European and tended to be like capnography is good, and the small studies were American, tended to be capnography it's not worth it. Yeah. So that was kind of interesting to me. The other one was what was their statement about bias, potential bias? There was one thing.
It could be quite high.
It was moderate to low on the grade scale. So you want to talk about, what?
Well, this gets back to the qualitative evaluation of the study. So there's a whole process too that goes on behind the scenes, and usually they will document how they graded the quality of the evidence. So that was one of the areas we were talking about bias. So they'll have a minimum of 2 people on the committee read all the publications and then rate them, and they will look at the inter-rater reliability of whether they felt this was quality evidence. So that could be a source of bias if you've got people that disagree on the level of quality for that, for whichever reason. They'll usually document the discussion and how they decided what got included and what didn't. So it's the qualitative metrics. It's not as easy as saying, well, there are 30 people in this study and they looked at this and these are the outcomes. There's another part that goes into it, because you can bias a meta-analysis, especially if there's only a few small studies or even one large and a few others, by what you include. So the other part is the affiliations of the people who are making these decisions.
And in fact, they weren't blinded. There's only like 2 blinded studies to find out if capnography alerted anybody, and then the rest, everybody in the room knew.
In the GI suite.
In the GI suite.
Which gets back to the point, right? So, and when you see,
so that's why
graphs,
there's potential bias. And was it in? I'll go on. I found something in the. 5 of the 8 studies were not blinded.
How would you blind it?
Well, what they did is they had capnography, and then they had events. So did they have events, and would the capnography, was there a correlation with what the capnography showed? So if you had a place that didn't typically use capnography and they were introducing it, then it's, I don't know if you've seen that big study about BIS monitors and awareness. They hid the BIS monitors from people, and they could just give anesthesia as they wanted. So, and then they looked at whether there was awareness in the BIS. Would the BIS have, and it's really hard because awareness is so rare.
Well, this gets to it too. A key point with any monitoring technology, it's very difficult to prove its utility, because a lot of the burden of proof is on maybe a mortality benefit. But if we had a really high mortality, we'd have a bigger problem, right? So it's one of the challenges. It's almost, besides pulse oximetry, which was sort of a clear utility when it came out, it's still hard to document that knowing something additionally impacted patient care. So that's what a lot of devices struggle with, and it sounds like capnography is on the same trajectory with BIS, that proving you absolutely need it for good outcomes requires massive trials, which are very expensive. So that data may not be available. So that even the fact that the expense doesn't justify doing these sort of studies limits what you can combine or what's available.
Yeah. So the ASA guideline one went into pretty good detail about the different kinds of bias that can be introduced at every step and how they use that. And I think it goes also for meta-analyses, that, everywhere from the literature review to, how they go about finding articles. And and there's a grade for basically everything. This one, they ended up with only 8. So it's really not that horrifying.
But do you need more studies? How would you know?
So what's the mortality expected for a GI procedure?
It should be,
Procedural sedation.
yeah, it should be phenomenally low, right? I would expect 1 in 10,000, 1 in 100,000.
Yeah, I can say 125,000. I'll just make it.
Yeah.
So you'd have to collect all the data at this institution for like 10 years, right? With no change in practice except one arm gets CO2 monitoring. There's no way that we could ever get that study in one center. And then figure the multi-center would be prohibitively expensive.
Right.
Excuse me.
So do you need to prove, it may still have utility without having a experimentally provable benefit, right, on mortality? Because everyone in this room uses capnography. Maybe not for procedural sedation necessarily.
I mean, one of the things that makes this really hard, and we talk about this, that it just may get more interesting as GI gets more, or any procedure gets more complex and the cases get longer. So one of the big innovations when I was a medical student becoming a resident was the idea that people having colonoscopy should get oxygen.
Really?
Yeah. I mean, you think that's obvious, but no. So, and then this idea of pulse oximetry came along, and they were like, well, crap, we're giving everybody oxygen, nobody's going to desaturate. So that, so then they had to prove that, and now you've got, well, if you have capnography and you can see people slowing their breathing down, yeah, they're on oxygen, and eventually they're saturated, so it's this cascade. So to answer your question, I think as time goes on and these events become, longer, there's more bolder things being done instead of like a sigmoidoscopy, for crying out loud. I mean, that takes, 5 minutes? Is oxygen really even necessary? A lot of people thought it wasn't. So
Let's go around full circle. So Josh doing
yeah.
is looking at not giving oxygen, supplemental oxygen to critically ill patients in the unit. Because hyperoxia is also found to be, if not more detrimental, equally detrimental.
The Goldilocks principle, right?
Right.
Yeah.
So this gets back to the point of how do you know when to change your practice? We've talked about that with RCTs. We've talked about it with retrospective studies. So monitoring's come up as one of these sort of soft calls, right? Capnography may be helpful if you're not watching your patient, you're just doing your colonoscopy, and you don't know they're not breathing because you're not looking at your patient, you're looking at a screen, right? So another piece of change your practice is this idea of implementation science. It's a discipline of, there's a whole part of finding new treatments, new therapies, showing that it's effective. But there's another side to that. So once you even have the trial, it's how do you get that information into clinicians' hands, have people believe it and start to use it. That's a whole discipline unto itself. So what are some of the barriers you can think of? I'm trying to think of some of the newer things that aren't widespread. Not necessarily monitoring.
So train of form monitoring.
There, yeah. Right.
There's quantitative, it's on your boards. You should have the accelerometer quantitative train of 4.9 is recovered. Did anyone use one of those today? Data says it will predict really well. It works. Why is it not in every OR?
Too expensive.
Yeah.
Determine that. It's cheaper than a capnography. Capnograph. We have those.
So that data is probably from 15 years ago at this point?
What?
Maybe 10 years, the accelerometry.
Well,
at
there's
least,
been
right?
continued data showing it's been important. It's been up to a vote at the ASA for adding it to standard monitoring, and it's been shot down 3 times.
The data's there. I mean, they have the trials. This works. Post-op pulmonary complications are reintubations, it worsens morbidity, mortality. What's going on?
Are you looking for anything in size or?
I don't know. We do all kinds of echo, right? Invasive.
I feel like that outcome, that like 3 week later post-operative pneumonia, is not necessarily linked to anesthesia, and so it's, you know, it's not. It's hard.
Post-op reintubations are. I mean,
They are.
We own that.
Right.
Yep.
So what happened here? And why are we tried to institute these things? We even were evaluating. And it's also, there's, I think, a publication coming, isn't there?
Oh, I don't know.
From here.
Oh, I haven't seen it.
So what we ended up doing kind of uniquely here, I didn't think about it as being a potential study, but Mark Krause, who has been running with this, is we did a switch, almost instantaneous switch from neostigmine to Sugamidex. So this whole idea of monitoring train of 4 ratios was almost made moot by giving Sugamidex because everybody gets the 0.9. Almost everybody. Much higher percentage. Overnight. And things like reintubations and pneumonias, post-op pneumonias have, by using EPIC, have gone down. Went down at the same time that the switch to Sugamidex happened. So
The ICUs had already gone down. So we used to have those twin suction ET tubes for a while, because the maps were the thing. And probably 5-6 years ago, after everybody was in on this, kind of almost eliminated it.
Right.
That's, I mean, it's really just every so often there's a sporadic VAP. So CLABSIs, VAPs, we got close to getting rid of. Catheter-associated UTIs are still terrible, like double the national expected level. We're horrible on that. And hospital-acquired pressure injury, HAPIs, for want of a better term, you still than we should be. So I think we've almost eliminated that. Great. And reintubation, there'll be some sporadic ones that something else happened, they stroked out or whatever. There shouldn't be a paralysis issue.
Right. And a lot of the data was soft. I mean, from different, some of these studies. I mean, there were things like double vision, other things that patients were feeling that could have been residual. And yeah, we aren't measuring that. I don't think there's any post implementation of Sugamidex study there that we did. But the studies have shown that if the train of 4 is 0.9 or greater, there's a lower incidence. And virtually every study with that showed that 40% of patients hitting PACU when there's only neostigmine available are below 0.9.
So when do you need a meta-analysis? I think Sugamidex is a good example of when you don't. Right, there's no nuance there. It's like a light switch. You go from this was a problem, some other way it's been solved. You didn't need the monitoring necessarily. You have a new tool, a new drug. So do you think that speeds implementation, right? Where's something that's you can think of that? What's the opposite of that?
When the data, all the established data are more equivocal, like any one a study that's clear that, or a guideline that tells you what you should or shouldn't be doing, I guess?
So I think we brought it up in one of these other sessions. What about the choice of anesthetic and cancer recurrence?
Yeah.
There probably is I think there is a meta-analysis on this, actually. But when you have something complicated without a clear causal chain, right? Because to really target a problem, you need to know what causes it, what modifies it, what goes into that. When we're giving a drug and then it's only partially getting reversed, there's a very clear causal chain. So that when you break it or you solve that issue, the problem evaporates. But metastasis is as different as the people, the cancers themselves. So how do you know whether your anesthetic choice has anything to do with that? Right? You come back to all the problems with RCTs. If you have heterogeneity in the populations, you have practice changes. This is something that would require an enormous amount of study, and probably the way the whole cancer field is going, you go to subtypes. The more tightly you define your population, you have a better chance of narrowing it down to the causal chain, right? But if it's a big soup of people, you're going to lose that signal. So when you come across a clinical problem, it's worth reflecting on how would this be answered. So if you have this toolkit of how do you even know what to do in medicine, right? There's sort of what you're taught. There's the guild system of like clinical practice, what's been done. Then there's the more research side of things, but some things aren't studyable. So if you put it back into terms of how would you even know what's going on with this, you can start to understand what might be known and inform your practice that way. Some things are less knowable because they're more complicated with that. Multifactorial.
And you're going to see a lot of studies.
A lot of bad studies.
Yeah, don't be changing your practice every month when the new journal comes out.
Yeah, and that's the idea behind this series, is to give you the tools to recognize when to change your practice based on new information, and when to be skeptical, or at least be able to evaluate what's going on with that.
Right.
Never be the first and never be the last.
Well,
Unless it's Sugammadex, then you're fine, right?
yeah,
I wish I would be the first.
Yeah.
but there's another one that's is becoming common here, and I think the jury's out, and there's not a lot of data for it. So I'll be watching. It is this introducing Precedex into infusions into the over. We don't know the basis for that. We don't know if it's that good of an idea, but it's being done. It's not bad. We don't know.
Well, the best data I know, that one you may be aware of some other data, was the post-cardiac surgery, that paper in circulation. They had this sort of bubble phenomenon like we had, where it was like super expensive and then it got cheap and everyone used it. Or the same with Sugammadex, it just got introduced in practice, and they compared before and after. And they saw the relative risk for mortality was like 0.37, which is a phenomenal number. That means the number needed to treat was really low to prevent a death even. There's a lot of issues with that study, but it sort of rapidly got adopted for other reasons, and I guess it wasn't obviously harmful. Did you notice a big change in the ICU when dexmedetomidine became?
We've been through like different cycles. So actually, Dr. Fragan did the phase 1 trials back in Chicago in the 90s. It was for anesthesia purposes. A couple of years later, we did a phase 2 in the ICU to compare it to the usual stuff, which was like morphine and Valium, IV. Clearly, there was a different outcomes. And then it got orphaned for a while, and then we came back for
That'll be interesting to see
DTs,
where it's
treatment of that versus X, and then it became delirium, close to whatever. So, I mean, it's been trying to find a home. I think it's good in the OR, and that's my impression. The units, I was never always that overwhelmingly enthused by it, and it's also finished expensive. When I started here, it was like $4,000 or $5,000 a day. Just stupid. Propofol, when it came off, was like $20 a day. That was expensive before that. So Precedex seems to be smooth, and
Yeah, it'll be interesting to watch. We're doing these things in front of the literature.
Yeah.
I mean, it's been shown for one thing, and then it just, well, you know, it's just interesting. So it'll be, just saying, keep it on your radar.
Yeah, pay attention.
Pay attention. These are changes.
I think
Change
I don't think
practice.
it's good or bad right now.
And you can't know, and I don't think there's a good argument for or against necessarily, but beyond your own experience with it. But it's worth being able to look and see what literature is available, and to at least know the moving parts that go into it. Okay, great. Thanks. Sorry for the late send out of it, but we got there.
Thank you.
Thank you. Thanks.
Thanks. See you once Catmar's going to be here in a little bit, so just. Why don't you have a
I think we're going to do scandals. Scandals. Retracted.
Oh, right.
Egregious.
Grow up a little bit. Stop being scandalous.
Coming soon.
Yeah, before it's
Showing the authorization.
There's actually
Yeah, they're different metrics, so that one's. Yeah, which this is the one that did show it.
Okay.
This is pretty common.
PCI from Palace.
Again, so it just tells you that
Cornell's punctures coronary artery when they were in the
They probably don't think you're there.
They didn't know why.
So
Yeah. They already had it in house.
Yeah, they're all
It was a large hole coronary artery.
Fun time.
yeah, we have. I think it's before. 26.
No, I just needed, I didn't have much.
Retraction.
Oh yeah.
Neuro.
Good stuff.
No mustard?
There's Dijon.
Heck yeah. Wait, you do that for Dijon?
Good. That's a good point.
No shame.
I really don't want to waste the story.
Chip's very good for Dijon.
Not too good for Dijon. It's gotta be on certain samples.
How interactive it is.
Hopefully it's low pressure. That's the idea too. Because then my sister loves start to learn and at least think about these things.
It has its place. I'm not talking.
It feels that way.
Oh, yeah, you were right.
Yeah, so I was
Yeah, that's right. It's like, you were there like, was it?
You are right. Nora.
Read the journal article.
How's that?
Nora, not Nora.
Well, I would do
It's
that.
interesting.
Yes.
And Glenn was, but we were like, we were embarrassed the
PCI
person by interrupting him.
But, yeah.
Whereas this way, you know, we made it very clear that we're interruptible.
But it was in Pella
Oh
support.
yeah, it's a conversation.
Stop you when
Why
I
is
got
this
some, a thought.
Why are they not doing this in OR?
It was in the
We'll do this on a cycle and repeat it. We'll
Okay.
just swap out. Keep
But-
the themes the same, swap out.
You do like IR and stuff too for this?
Yeah.
I was thinking of presentation showing some of the
I don't have
heterogeneity stuff. Why would somebody do an analysis when the heterogeneity is so small?
But yeah, they poked a hole in the right coronary when they were editing it.
I think because it's an even better argument. You've got, I think
Pericardial
it
effusion.
gets listed 1A evidence.
We had
So
an
let's say you have like
pericarditis.
a good example is like,
I did, so.
because there's bajillions of dollars in
I would
this,
say-
they will do, you know,
And telling the lady,
10
it's
million.
gonna be okay. Breathe.
So,
Haley, what happened with your?
There's a
She's like, I feel like
choosing
I'm
out.
going to a dark.
Oh my god, it flooded, so they're hopefully fixing it today. My landlord just wrote, all fixed.
When you die, come back
And
tomorrow.
then woke up
Just
the next day,
remember
like, sat down,
what it's
and
like.
just,
You'll have a very
in my
unique
bed, right?
perspective
So like
on
had gone through the wall,
discussion.
and like I was like, Oh my god. I wonder if I affected down there. I don't think no one said anything. So thankfully no. But like, cause you know, like with a certain amount of water,
One of them that I got was soft.
but yeah, like, I went through, I had like 10, 15 towels, like I went through all of those trying to
Try it.
and I had 2 rolls of paper towels.
That was my
that.
initial thought. I was like, oh, this is very good.
But thankfully, like, no, like, nothing to my stuff was damaged. Like, I didn't have anything on the ground.
Experience.
So it was fine.
Yeah.
But yeah, I just like woke up.
Is it? This soft?
I
bet if you like
right, yeah.
stuff it in like red or something, I don't know.
So yeah, it's like
Somewhere
clean water,
moist.
I guess. Still, it's like such a pain, but waking up, you're like, what is this? So yeah, now he's fixed it, which is good.
That sounds not good.
How's your day today?
I mean, it took more days, really expensive.
Very like long and standard, and then
The
pads are the next pack.
Ooh.
Cookies all night.
I know. Take them all with you.
Yeah.
Want to make your rounds with it.
Yeah.
You're in your OR?
Have a cookie.
I just finished taking my view.
The practitioners
How
who
do you
are
think?
most living on
I
this.
rocked that. Oh,
Just
All this overwhelming evidence.
I want to do that more.
I know.
Wait, you doing it free hour?
I did it way more at the VA last year with Dr.
That's right.
Oh, yeah.
Oh, I know who you're talking about.
Yeah, he'd always be like, I was like, oh my god, go get things done up. Yeah.
Yeah. I love him.
No, so I'm like, well, shoot, I didn't have any of that ready for that. So I was like, go set the room after. Yeah. That's the place where I did it.
And so quick.
Oh, you run.
I'm in a room.
I can almost see like a volunteer.
So I haven't even, yeah.
Good intention, old like vet volunteering in the OR.
Journal was alerted.
That'd be really
And there's some people there
Did you have some sick case or something today?
to develop
What was your first case?
software to analyze specifically.
16-year-old. Oh, that's what SMA. She kept saying it was an SMA case. I was like, I don't know what.
Well, what happened?
You know, she was like, I gotta go. I gotta go. Yeah. I know. That's why I was like, why is she doing like a vascular? Like it said you were in an old.
Science. It was one of the major.
So confused. Yeah. What did you have to
So,
do for that?
taken different.
Dude, yeah.
And spent a lot of time. Fits this corner. Well, that's what she said she was doing. Was like, she meant to go to the real control.
Right, so they
Machine.
But then why would you go to the trouble of?
Apparently we can.
some of them were
Dude, her mask older.
It was the same size.
Dude, this is like
They were in control. It does raise questions.
Tom, do you mind if I close this out?
Oh, yeah.
Oh, okay.
But yeah, so that's
well, yeah.
anyway, we're just looking in the
Yeah.
reflection about how people find this stuff.
Would you?
I don't like this, like the plagiarism software. It's pretty advanced.
More or less.
That was funny because
That's
Steve,
AI stuff too.
it was Steve Schaefer, who's an editor, who uses the software. It caught him.
No, I'm just gonna hook in. I'm just trying
It said that you left it, it's the same methodology.
Methods, I feel like they, like, you're parsimonious with methods, right? Like you want the minimum number of words to explain what you do.
Yeah.
You're gonna reuse your methods, right? I feel like that's not plagiarism.
really
Super bad.
You say as
Oh
previously.
yeah, still applies. I mean,
Liking it, not liking it.
like it was kind of like reviewing what happened in week 1 and like just having.
He said, I didn't even. When I saw it, I was like, oh, yeah, of course I did that. Yeah, of course I did that.
Very interesting.
is she like too anxious
Do
for
it.
your idea or something? So you give her P over set or something?
This is truly paradox. I'm not even kidding. It's like exactly.
Your hands are shot. No wonder she's running in another.
And then your parents are lunch.
Or did he move it to tomorrow?
No, he has 2 today. Once the first one started at 2.
Great
So he's got 2.
He did it. Maybe was it December? It was December.
Did you use those times for him, or?
Yeah.
Oh, those were without.
That's great. It's booked till like 7. When we
We got one.
on the dot. Exactly as well.
Yeah, I think it's scheduled at 3.
Well, that makes more sense. I was like too embarrassed. I was like, at this point, it's too late. I can't ask this.
That's so funny how that works.
She had said it like 3 or 4 times. And I had especially when I'm saying it, I was like,
That's so funny how that works. Yeah. You pass a point.
just like, Mr. Jake's case.
Or you could not.
That's right.
Oh, good luck.
Thank you. Oh, that is.
I wouldn't have if it had been like the first or second time, but she had said it many times, and I was like doing other things and had just not acknowledged it. So.
Wait, what were you doing?
I was doing tips. Like I was in her other room.
Oh, I see.
So she was like running back and forth, which was good.
What just happened?
Really? I've never worked with her as president.
This was the first time I worked with her during the day.
Weird.
I
It
don't know.
was working.
She was nice.
I did one case with her. Like I was Christina was? Yeah. Are you working with her?
Oh,
Okay, it's back.
TS.
Let's try this again. It's so weird.
Is it like a wire connection issue or something? It looks like it flickers and then.
No, it was there, and then I went to
Yeah.
presenter view, and then I got really angry, and then it went away.
Okay.
Let's try again. All right, this might be a kind of. Here, let me email it to myself and see if that'll work. Sorry, guys. I know it's there, and then I try to like do the presenter view, and it goes
You
away.
just do
and
it
it's,
from the normal view, and
I guess I can. That's kind of. All right.
We don't want to see all the hidden secrets.
I know. I was gonna say
There's not really any secrets. I just don't know if
question
like.
answers are down there.
Let's see here. You set up to be on multiple displays.
Oh, that it just went away. I don't.
On its own.
Awesome.
All right, I'm gonna email it to myself.
I will. In the next app.
Oh,
Without a doubt.
knowing that they're there.
Oh.
Yeah. Stop.
Yeah. What's the display function on that?
It's not on any of my like. I swipe between all my desktops. It's not there. Not on that one. All right.
There's no way to say which display to show it on.
Hold on. Let's try this. Disconnected right now. What the heck?
Yes.
Presenter view should drop all of that when you plug it into the HDMI. It's something with this thing.
Fair enough. I mean, I'm dying. Yes. We can't all be as upbeat.
I'm literally dying regardless of the situation.
Even if you would give me a much vacation.
With my computer, I figured it out. Are you guys doing anything?
No. Well, we're on the arches for like 2 days. But I was just gonna sit on my ass. Stare at the wall.
Yeah, no, those are
space out.
Those are great vacations.
Yeah.
What are you guys gonna do with Arches?
Just because my wife was like, "You want to do something else?" I'm like, If you want to do something, just sure, whatever.
Yeah.
What's that?
I was gonna say, yeah.
I don't know, we're not climbing.
I was just thinking, you guys can do that, ever?
No, we don't, unfortunately. We're not,
So you don't talk.
Have you mountain biked at Milan?
I know there is, yeah, I don't know.
Alright. Just go to Wall Street. Go to Ash Road today. Yeah. So it's like right. Your view is good.
Yeah, no, for sure. I do. Well, my wife doesn't lead at all, and she's also pregnant. She doesn't want to catch me on lead while she's pregnant.
There are.
We'll see. There's a question where we're like
Further down.
Analyzing the volume stats.
What's that? It's like a little handle. Check it out. I'm gonna look and see if there's something like easy access folder or something or whatever. Mostly just doing it to get outside and relax and chill. I'm not too worried about it.
Cool.
This day and age with mountain project.
Keep in mind,
Alright.
we're only gonna be there for like 48 hours, so.
Okay, we'll just do it like this, like PC sketchy version. Okay, we're gonna try to move this pretty fast so you guys can go home
Awesome.
today. So post-op considerations, there's like a million things to talk about. So this lecture kind of pulled on topics that are in the, it's now called, is it TrueLearn? It used to be one of those other learning things that I'll give you guys access to. So it's kind of a random assortment of things, but cover some topics that should be applicable for the basic exam. All right, one of which is neuromuscular blocking agents. This certainly does have implications in the PACU because if you don't reverse people, there's significant risk for issues down the line. How do we monitor neuromuscular blockers?
Don't anymore because we have some Gamtex.
Not a good answer in the oral boards.
Doesn't matter, 60 per kilo for
Train of 4.
Yeah, train of 4. How good is that?
Depends on if it's qualitative or quantitative.
What do we have?
Qualitative.
Yeah. Why don't we have quantitative?
Because they're expensive.
No.
Yeah, it's expensive. It's a lot of technology. You know, we'd have to have like 50 some just to have one in each OR, let alone all the backup ones. And given that we have Sugammadex, there's not a lot of need, and I don't know that evidence is strong to say that having a quantitative twitch monitor really makes an outcomes difference. So when you're looking at a beneficiary ratio or kind of risk benefit analysis, I don't know that from a cost effectiveness standpoint it really makes sense. But if you do have quantitative, you can actually compare the height of the first to the fourth twitch and kind of what that actual fade is. Other things we can look at, clinical signs, right? So like when your patient's trying to sit up, essentially, before you extubate them, that's a pretty good sign that they're strong. But you can still do some of those strength things, even with a ratio of even 0.5. What about this inability to remove the bite block? So it's interesting. In one of the textbooks, that's actually someone looked at that. Essentially means that there's a ratio of like 0.9. It's extremely good sign if they can clamp hard enough that you can't pull the bite block out.
Oh, I meant like the patient trying to...
No. Like you're trying to take the bite block out and they're biting it.
Okay.
And I would say if they're doing that, just let them keep it. It doesn't need to come out. You're more likely to cause an injury trying to yank that out of their mouth. Within a few minutes, they'll probably open their mouth enough for it to fall out or for you to just gently take it out. This is just kind of showing what these things look like if we were to have some sort of quantitative, so you can actually see kind of how that fade goes. And then how do we reduce the risk for residual blockade? Obviously, routine monitoring, titrating doses, and not just kind of willy-nilly giving extra muscle relaxant when you hear the patient's moving, the patient's breathing, et cetera, et cetera. Like, get your own information about that because certainly I think you've probably all seen where someone's boving a muscle and it's twitching and the patient has no twitches, 0 twitches. Making sure that you have adequate recovery before you reverse. So I was giving a mock oral a few weeks ago, and one of the questions was, patient at the end of a case has no twitches. What would you do? Patient said, well, give 16 milligrams per kilogram of Sugammadex. Would you really? Who would do that just at the end of a case? Why not?
The end 10 minutes after the beginning.
No, at the end of the case, just no
Do you
twitches.
just give 100 of rock or something?
Does it matter?
No. Well, I mean, yes, because then you probably know what's going on, but.
Right, but does that still justify giving essentially the emergency dose of Sugammadex, right?
If you have an airway in place,
Yeah.
all you do.
It's a very controlled setting. You know, worst case, you take the patient intubated to the PACU, right? I think that it's great that we have Sugammadex for ROC. It gives us the opportunity, I think, to be a little more liberal with using ROC for things like RSIs and patients that we aren't as sure about. It gives us a little bit more confidence in terms of being able to do something if all of a sudden you're in that can't intubate, can't ventilate situation. But I don't think that it means because you're trying to turn over the room, you then have the opportunity to give a dose of medication that certainly does have side effects, especially with those really high levels. So waiting till it's appropriate to give reversal, I think, is important. You'll probably at some point in your career be sabotaged by the break where you leave and you come back and someone just got rock and they are done and you don't have any twitches. And you know, it happens to everyone. You just wait for a few minutes and give some reversal. And then we have, especially Sugammadex, a nice titration protocol regarding kind of dependent on how many twitches you have. With neostigmine and glyco, has everyone given neostigmine and glyco? Okay, just making sure. You can still do that. I tend to be a little bit heavier handed with that because I think that it just doesn't work as well. And if you've never seen a floppy patient, it's really not a fun experience for anyone involved, including the patient, because they feel very subjectively weak. And I think that with our qualitative twitch monitor, it's kind of hard to determine how you would determine, oh, I should just give a half dose of neostigmine if you've been dosing rock throughout. If you gave rock at the very beginning of the case, it's 6 hours later, I still tend to give reversal, but I would be willing to give a lower amount at that point. People have strong opinions on this in many different ways, so I'm sure you'll hear the opposite of what I just said. The other thing we want to look at is, kind of considering where you're monitoring and what muscle groups you're most concerned about. Right? Because we want to make sure people are ventilating well at the end of the case. In addition to not being floppy with their extremities, I think really that kind of central muscle strength is of the utmost important. Luckily, the diaphragm and kind of those core laryngeal, pharyngeal muscles recover pretty quickly. The adductor pollicis is one of the slower muscles. So if you're monitoring the adductor pollicis and it has recovered, assume that those central muscles have also at least one or two twitches back. And if you're monitoring kind of that corrugator supercilii, that should have about the same, although on the face, it's somewhat unreliable what muscle you're actually monitoring. I'm sure you've all seen, you're trying to monitor this and you're twitching the jaw. So always kind of adjust things accordingly. So when we do have residual paralysis, it's kind of when we're under that ratio, when we don't have kind of that equal 4 twitches. And patients will feel subjectively weak. They'll have visual disturbances because their extraocular eye muscles are weak. They may have weak upper airway muscles, decreased airway reflexes, impaired hypoxic ventilatory response because they just can't breathe as much, and they're at risk for aspiration. So while this is kind of a rare thing to happen, it's certainly one of those things that you're going to be thinking about, especially if delayed emergence, decreased level of consciousness, hypoventilation like you had in the PACU the other day, making sure that reversal was given, that's not what's happening over time. And then as a result, you can kind of see, not surprisingly, what happens. Hypoxemia, obstruction, atelectasis, pneumonia, increased time in the PACU because of some of these other things. Okay, oops. Questions about that neuromuscular stuff.
One thing I would ask is just supposed to Gamma X, what is the appropriate, when I first started, it was you need to have at least one twitch back before you give Gamma X. And then I've seen actually in the last month people say, well, if they have one post-tetanic twitch, what do you, like, and I'm sure it's varied, the answer to this is varied as well. But
I think it's varied. I don't really count a post-tetanic twitch. You're kind of like, I don't know what the best analogy for that is, but you're essentially creating the scenario that you want. Like, you're like, I really want to reverse this patient. Let's see if I can make them have a twitch. Let's flood the receptors and then try to get a train of 4. You're kind of cheating, honestly. That's another one of those, like, let's wait 10 minutes and get an actual twitch, especially with the rock that we have now. It's going to be gone pretty quickly, right? Like, there might be 9.75 milligrams in each cc, but they don't work. So they're going to go pretty quickly.
I had that exact scenario on call the other night. We ended up giving 100
And waiting and then giving more.
And then giving more.
Yeah.
I've had people like say, just give the full 200. It's a single dose, and like the anaphylactic, like if it's truly anaphylactic, it doesn't matter what the dose response is.
That is true. So I think it kind of falls under the why are you giving more than is necessary. I can't say that I've never given a test dose of reversal to see if it helps and then giving more, but I think it's never the wrong answer to just wait until it's appropriate to reverse. Even though there is a lot of pressure with efficiency and that sort of thing, it's also, patient safety comes first. But do you have a question, Ken? Do you figure out to say something?
No,
Okay.
it's talking about the rock that doesn't work.
Yeah, it's really unfortunate. Myalgias. Has anybody seen patients complain of myalgias?
I had a patient come back to the ED the next day.
Really?
Wow. It was like, and everybody, the medicine service was super concerned. Anyway, I was like, I'm pretty sure it's just the sex, guys.
That's pretty surprising, actually.
Yeah, I'm pretty sure it was the sex.
What were the patient characteristics?
Just full body muscle aches.
Was
And
it
then he had an elevated CK.
man, woman,
Man.
young,
50s.
Big guy.
Oh,
Yeah, big.
yeah. So myalgias are most commonly associated with SUCs, but patients can get them after propofol induction. So you can get myoclonus with propofol that can lead to pretty significant myalgias afterwards. Sometimes patients just with long surgeries are going to have myalgias from laying in that bed for a long time. And, CK elevation after surgery is very, very common just because of that. You get essential little bit of muscle breakdown from either the surgical process itself, especially orthopedic type surgeries, but really long surgeries just laying on that hard bed can also be associated with that. But they're most commonly associated with giving SUCs because you do get that fasciculation. You can see this is one of those things where the incidence is essentially 0 to 100%. On average, about 1 in 2 patients are going to get it.
Is that specifically in PACU or that's
In general, myalgias after, yeah.
Because if it's similar to working out, it's rare that it's immediate that you're sore.
Yeah, this isn't just in the PACU, but sometimes patients will complain in the PACU that they're just a little bit sore. We think that it's probably due to the fasciculations in that kind of uncoordinated contraction, that initial. Why do fasciculations happen? Why would this happen? Yeah, exactly, because succinylcholine is essentially acetylcholine combined. What if we try to prevent fasciculation? So how can we prevent fasciculations with SUCs?
Small dose.
Okay, how much?
Like 0.1 mg per kg.
Yeah, even 0.05, like a very, very low dose. What's the risk of giving a little bit more than that?
Clinically significant.
Yeah, patients start to get weak. That's not a good, that would not be a very pleasant experience for the patient as they're drifting off to sleep, feeling themselves essentially getting paralyzed. But unfortunately, giving that little depolarizing dose doesn't automatically prevent fasciculations. So I typically don't use that in my practice. I think the patients I'd be more likely to do it for, what do you think? They'll bring it.
We got like 15 of us in a dissection.
Oh, shoot. Is it a bring back?
The dissections, you don't have to.
Jeff.
The type A dissection.
Is it the one from overnight?
It just came in.
Oh, okay.
Came in through the ED.
Gotcha. There was one overnight.
The people that you probably want to do it for, the same people that you don't want to do it for, maybe, or that you're.
Potentially. So let's say, who do you think is more likely to have a myalgia? A 74-year-old thin female having a total abdominal hysterectomy, or your 35-year-old muscular guy having a knee scope? Yeah, absolutely that guy. Ambulatory patients probably have a high risk because they're getting up, they're moving, those muscles are now going to be worked, and it's like you said, if you work out and then you lay around the next day, you aren't quite as achy as if you get up and you're like running around and you're like, oh God, why? So you can almost kind of predict what's going to happen, and you can even see some of the people that have the most violent fasciculations. Like, oh, they're going to be a little sore. So treatment of this is kind of like you would do for any other type of myalgia. NSAIDs, a benzo can do it if it's really causing anxiety for them, but nothing special should go away in a couple of days.
Have they ever has someone ever gotten rhabdo from?
So not from just fasciculations, but certainly that's the concern in a lot of patients with muscular issues. So all the muscular dystrophies, the concern is just inducing rhabdo. So, if patients have underlying muscular issues, then you would be concerned about that. All right, so a question. This is a really long stem, sorry. 65-year-old man underwent GA with DES, fentanyl, and rock for an elective posterior lammy spinal fusion. Now is complaining about respiratory distress. He's breathing 20 times a minute, shallow, relatively hypoxemic on a face mask. And at the end of the procedure, he had 4 twitches, no fade, didn't get any reversal. Had a strong hand grip before extubation. What would you do first? Sorry. So would you mask him? Would you reintubate him? Would you give Narcan? Or reversal?
And this is maybe the assumption that it was at the beginning of the case that he got the rock and it wasn't reduced.
This is the story you have. Just what are you going to do first? You're in the PACU. Kenji, this patient rolls in.
I mean, Twitch monitor.
Okay, get a Twitch monitor, but while someone's getting that, what are you going to do?
Yeah, I would probably, set on 10 liter. If they're stable on 92, they're stable, so I think you can assess twitches and you can assess their opioid if they need naloxone. It's not like opioid breathing, so.
Yeah, I think it's unlikely this is probably due to opioids, right?
Could be inadequate reversal or could just be true, atelectasis causing respiratory distress, so.
Yeah, we don't really know the whole story. I would say probably at least get some stuff to the bedside to mask if you need to. Check twitches, potentially give reversal. There's not a clear. What's that?
If he's talking and he's awake, would you still put an oral airway in?
Yeah, that was the only thing I was.
Yeah.
It depends. I think how.
I think the point is AV
Yeah.
before anything.
Correct. Sorry, it's not the perfect question stem, but the point is just give supportive measures while you're investigating what's going on. Okay, so then totally switching topics, postoperative myalgias. What are you going to give that patient?
Toradol.
Yeah, perfect. Not a fentanyl.
Well, they already have a fentanyl patch. We send them on the
No, they're healthy. So I had a patient yesterday who drank a couple times. That was his answer. Just a couple times. Okay, you're 19. Sure. So switching totally. Any questions about all that? Sorry. Okay. We'll keep going relatively quickly. So respiratory concerns. There's a lot of different stuff within this category, just kind of some reviews about physiology and then a few of the other things. So these things these things are tested all the time. However, you can kind of visually remember what's a volume, what's a capacity, how that all relates to each other, I think is important because it's a very, very common test question. I don't think we really need to go into it. This is just something you have to memorize before the basic exam. Okay. So this is a patient I think we'd all be somewhat concerned about in terms of respiratory outcomes with surgery, obese, looks like maybe a thick neck, big belly. I would look at this patient and think they had sleep apnea, they're going to obstruct. And so other things we're worried about, if you lay them flat, they're going to have pretty significant atelectasis. And that becomes even more so after induction. As you have the chest wall collapse, the more obese you are, the more restrictive you become. It's difficult to ventilate these folks. If you're worried about this, you can maintain some degree of spontaneous ventilation. I don't think anyone really does that for induction unless you're doing it in the ICU. You're worried about other issues, tamponade, that kind of thing. You usually make adjustments from that. So who would have RSI'd that patient? Or thought about it?
Would have thought about it.
Why? Just seeing that patient, no other information.
So not knowing anything else, potentially there's out of these obese people, there is a concern that, they're diabetic, they have poor gastric emptying, that could be a higher aspiration risk.
Okay.
You can control the airway quicker.
Yeah.
Meaning put an LMA in and then tube them if it's truly that bad, or have a quick look and go to your LMA first.
What else? What else are you worried about?
And if you already
Recruiting everything.
Yeah, okay. So
Yeah.
they're going to desaturate really quickly, right? So it's hard to pre-oxygenate or denitrogenate those folks because it's hard for them too. We've dropped their FRC by laying them at least semi-supine. And for them to take vital capacity breaths like a non-obese patient, it's difficult. So really kind of recruiting that FRC is very, very hard. And I would agree. I would think about it too. And I think, getting in the habit of an RSI doesn't just mean I'm worried about aspiration. All it means is I want the shortest time from inducing to tube in the trachea, right? That's all it means. So if you're worried about someone desatting, you're worried about someone aspirating, those are both reasons to do an RSI. You're worried about, impossibility of ventilation. Those are not, incorrect reasons to move ahead with a rapid sequence or a modified rapid sequence induction. All right. Reversing or preventing atelectasis. So if someone kind of slowly, say this guy slowly desaturates over the case, I think, progressing atelectasis is a concern. So what's a maneuver that you can do to try to prevent or reverse that? Right, so what's that mean?
You are wanting to re-recruit those atelectatic portions of lung.
How?
You can do a sustained inspiratory hold.
Okay.
And I think our machines do it, but we can also do it manually.
Yeah.
Half of our machines do it.
Like newer version.
Yeah. You might be able to find it on your machine. So you can do it a sustained inspiratory or just a few big vital capacity breaths. And I think, and then what setting might you adjust on your vent? PEEP, right? So I think, getting PEEP on as early as possible. And if you forget to turn PEEP on for, 15 minutes, an hour, and then you realize it's not on, doing those maneuvers before you turn it on, because PEEP, 5 of PEEP is not going to magically open atelectatic alveoli. You need to open those first, and then the PEEP keeps them open. Right. The west zones of the lung, also very important for the basic exam, and as you guys move into things like thoracic, important kind of understanding these concepts. I'm sure you all remember this from medical school, but essentially in zone 1, you have more ventilation than you have perfusion, and so you have collapse of the capillaries. In zone 2, it's more of an equal ventilation perfusion, and in zone 3, you have more perfusion compared to ventilation, so relatively unventilated airways. What zone do we want to have the most of, ideally? Zone 2, yes, exactly. Okay. And then this is important when it comes to ventilation perfusion matching, when we're looking at dead space against shunt. So what is a shunt? Correct. And then dead space is? Right, exactly. All right, so shunt is perfusion without ventilation. So essentially the blood is just going through, You're not exchanging any oxygen into that blood, and you're not taking carbon dioxide out of it. It's usually in the dependent portions alone. Again, this is kind of the zone 3 area. Maybe worsened with high FiO2. Why would that happen?
Decrease pulmonary like the places that are hypoxemic, both pulmonary vasoconstriction are suddenly open, and then they go by not knowing.
Exactly. All right, and then dead space is, as you said, the opposite. Considering anatomic versus alveolar, more of those conducting airways versus the actual kind of the zone 1 that we're thinking of areas. Don't really ever have a significant change in anatomic dead space unless you're doing things like one lung ventilation, or you have a huge mucus plug, that sort of thing. But certainly you can have changes in the alveolar dead space. Okay. Response to CO2 is also really important. Normally, when you have increased CO2, your body responds with a compensatory increase in respiratory rate to try to maintain that normal acid-base homeostasis. However, anesthetics typically decrease that response. And so patients can become hypercarbic, and then they can become somnolent, and then they hypoventilate, become more hypercarbic, and get into this pretty bad cycle. So certainly this is something we need to pay attention to as we're waking patients up and as we're ventilating patients in the OR. If you're trying to finish your case and get somebody extubated and they've just been slowly hypoventilating, with an LMA, or you've turned off the vent at the end of the case and they hold their breath and don't pick up a good respiratory rate or tidal volume, I think it's pretty easy for all of a sudden your CO2 to be 60 once you actually ventilate the perfused areas of the lung. I'm sure you've all seen that. All of a sudden you give an assisted breath and your end tidal goes from like 40 to 72. That's why I'm not waking up. So, just kind of keeping an eye on that, I think, is important. Because that's part of kind of meeting your extubation criteria, is that you have an appropriate CO2 at the time of extubation. In terms of what happens, initially, opioids will move things to the right. The slope will start to come down with higher doses. Same thing with volatiles. Really high doses of barbiturates could do that as well. We don't use a whole lot of barbiturates anymore in the perioperative period. And combinations of really any of these drugs are going to amplify that effect. Okay. I don't have my notes to show exactly what happens, but essentially the more you're giving, this is kind of falling off to the side. All right. And then hypoxemia is also a really important driver of ventilation in awake patients. Usually, again, increases your minute ventilation. The carotid body chemoreceptor typically does this, and this is, again, depressed by most anesthetic agents, even at very low concentrations. So patients getting max are going to be affected by this. Even just giving sedation, this can lead to hypoventilation. I'm sure you guys have all seen that. Is somebody calling? Okay. And then in terms of respiratory effect of the surgical incision, we kind of talk about this. You guys have seen this on APS, reasons for patients to get thoracic epidurals. We talk about postoperative respiratory function, more impactful in the upper abdomen and thoracic regions because we think of those as kind of the most splinting risk. And so I think those have been shown pretty well to improve outcomes, decrease risk of pneumonia. Patients that you're worried about, extubation would help with extubation. I kind of told how we prevent or mitigate that. Good pain control and good positioning as well. So, the patient that has slid halfway down the bed is going to be worse off in terms of breathing mechanics, especially when we're looking at obese patients. The chest is on their face. Those things can all be helped as you're getting into the PACU, kind of going through that initial recovery period. Okay. I think there's a couple questions and a couple kind of little grab bag discussions, and we'll finish up. So got a 63-year-old male that you're taking back to the SICU in post-op day 3 for progressively worsening hypoxemia. What do you think is most likely the surgical procedure that this patient had?
Open coli.
Yeah, probably an open colic. We don't do these very frequently anymore, but they do tend to crop up. These are definitely patients that you would think about doing a post-op epidural on when you have those
Last week.
that you have to open them.
They
Like
almost
6 in the
didn't
last
get an epidural.
6
I know. They're a little more common here than other places, but it's like a very low thoracotomy essentially is how that pain typically is referred to. Okay. Which of the following is associated with the greatest increase in physiologic dead space in a patient with a SIVO anesthetic? So in another way, say it again.
Increase. I was gonna say C.
The beach chair.
It's actually D. Yeah, you have more of that zone 1 as the blood kind of comes down to the basilar section. And you're still going to have that drop in FRC from intubating the patient, that sort of thing, and then setting them up. You have even more in terms of perfusion kind of going to that lower segments. C would be second most. Okay, so a little grab bag. So you're walking through the PACU, and you get called to come see this patient. You have a laparoscopic inguinal hernia repair, and the blood pressure is 190/95. What's your differential diagnosis, Kenji?
Uncontrolled pain, underlying blood pressure that's not controlled, full bladder, hypercarbia or hypoventilation. That's probably where I'd start.
Okay. Anything to add, Josh?
Probably super anxious and agitated and delirious.
Okay. Anybody want to add anything else? Just
I mean,
uncontrolled
like really,
hypertension,
like
basically.
rare things are like MH. There's, you know,
Yeah,
there's like a weird bag. But
That's like weird. Like, you don't have to mention those on a differential. I think a good way to do it is I'm most concerned about A and B. Other things I'm considering are these. You don't have to say the zebras unless it's like pointing you at that.
Yeah, okay,
Like,
okay.
their CO2 is also 80. Okay, well now I'm really concerned. Yeah.
I would say blood pressure cuff is too small.
Yeah, that's a good one. That's absolutely true. Especially in the PACU, if you haven't. Now that we have the one that travels with them, hopefully we're kind of the determinant that can get them the right size cuff, but that is certainly a risk. The other thing is sometimes, was his starting blood pressure 190/95? It might have been. What are you going to do for evaluation, Marcus?
Go see the patient, see if he's symptomatic, see if this is causing any sort of hypertensive urgency or emergency type symptoms.
Okay, what would you be looking for? What would you ask him?
CNS type changes, headache, any cardiovascular concerns, anginal type thing, shortness of breath.
What else are you going to ask the patient, Jessica?
Yeah, so just want to look at like indoor exam, so chest pain, shortness of breath, headache, vision changes, folate frequenturia.
Right, so that's like hypertensive emergency, right? But
And then like so pain. Like
Yeah,
pain.
yeah.
Do you have blood pressure
Right.
problems? Otherwise,
how are you feeling?
Yeah.
Just kind of those normal things when you'd walk up to a patient and get a quick assessment. Did he not have a Foley and now he's got urinary retention? Did they straight cath him at the end of the case? Those kind of things you want to just kind of figure out. While you're you can kind of do that scan of the monitor as you're kind of investigating with the nurse too. Have you given him any labetalol? Have you done anything? What's been going on? Has he already gotten 250 fentanyl and he's in severe pain? Is he confused? This isn't a whole lot of information. You kind of want to investigate a little bit more. Okay. Second grab bag, Jake. A 43-year-old female says post a total vaginal hysterectomy, is complaining of nausea and vomiting immediately as you get to the PACU. What are your treatment options for her?
So, for immediate treatment, I would think about propofol.
How much?
Give 10 or 20 to start. See how they do.
It's in your bag. It's fine.
Give a little.
Is that going to last for a long time? probably not. So what else are you going to give, Lauren?
Give her some Zofran.
Okay, so you could give another dose of Zofran. Sure. What else?
You could do Phenergan. You could slap a scope patch on there, knowing that's not going to work immediately, but then she'll probably continue to be nauseous.
Yeah, so scope's not a great reactionary treatment, but for down the line, this is certainly a case where she's having a high-risk surgery, and she's probably a high-risk patient as a 43-year-old female.
She would get some Reglan. She could get Compazine.
Yeah. So you're probably not going to do all three of those at the same time, right? Phenergan, Compazine, Reglan.
So I'm just listing. She
Well,
could also do
dystonia.
something like Advan.
Okay, yeah, so anxiety is certainly a contributor to nausea and vomiting. Who's given Haldol for nausea and vomiting? Okay, how much do you give?
I've actually never given it. I was wondering what dose.
Of people who have given it, how much did you give?
Like 1.
Yeah. 0.5 to 1. Has equal efficacy to droperidol and Zofran, actually. And it's just something we don't do very often because you can get from the pharmacy. It has kind of a stigma associated, but it's actually a really effective antiemetic, and it does not have the same black box warning that droperidol does. So I think especially in these kind of gynae patients that are the highest risk, I would even give it to somebody intra-op if you're really worried about nausea.
I know we talk about Ativan as being sort of preferred vendor to give Medaz.
Yeah.
Since we have it.
Yeah, if you have it, you certainly can. I think Ativan is going to last longer, and that's what the nurses are comfortable with. It's a little slower onset, but you can certainly give half a milligram or 1 milligram of Versed if you want.
Do we ever give or have here that medicine that I feel like pops up sometimes? Aprepitant.
Amend, yeah. So I think you can get it if you kind of have to bargain with the pharmacy. The problem is it's just very expensive.
Okay.
So I think it's used a little bit more freely out in the private practice world. It's certainly used in the cancer center, and I think you can get it. I just don't think it's done very often. Yeah. It's kind of like when we had a preservative-free morphine shortage. Like you could get a dose down here, but you kind of really had to support the risk-benefit analysis. Other things that sometimes come up is giving a D5 bolus.
So we did that today, and actually, whether or not it was just time or that, but she got better.
So it's something the nurses like to do it. It's really easy. It's very low risk. And you can think about like how I feel when I haven't eaten for a long time. It's pretty crummy. Getting a little bit of glucose, I think, can make people feel a lot better. So just a small bolus, like 250 cc's, something like that, and then hopefully they can start to tolerate some crackers or juice or something else. What do you think about discharging this patient? What would be kind of your marker to say, yes, it's okay to discharge?
Stay hydrated.
Okay. So can they keep things down, right? Are they going to, we really don't want to send someone home that's just puking all over the place.
Are they comfortable leaving?
Yeah, that's a big one too. Having a discussion with the patient, with the family, expectation setting. Nausea and vomiting is one of the more frequent reasons for unexpected readmission, and certainly something that we don't want, the hospital doesn't want, the surgeons don't want. So kind of getting things under control, even if they have to stay in the PACU a little bit longer. Things like cochlear implant, those are going to be some of the harder patients to get out in terms of nausea and vomiting, but those are also, I think, the surgeons are very good about setting expectations and kind of, you're going to be nauseous, there's nothing we can do about it. But yeah, certainly the ability to drink and that kind of thing. Okay. All right. I think this is the last one. So a 28-year-old male after a arthroscopic rotator cuff repair complained of difficulty breathing 15 minutes after extubation. You arrive at the bedside and you can hear a high-pitched sound during inspiration. What's happening? Anybody?
Respiratory stridor.
Yeah, it's stridor. Why? Okay.
We have a blog done.
Okay, why do you ask that?
Makes me wonder if
Do they look at
Yeah, but that would
interscaling
be-
and find it like the recurrent or in jail?
Yeah.
Yeah, like maybe if they tag the referral or jail.
Yeah, exactly. Are you worried about some sort of neurologic issue with the vocal cord? Was it a really traumatic intubation and it's some sort of swelling induced from that? Did they, aspirate something, or is there mucus sitting right on the vocal cords that's kind of creating a laryngospasm? So things to kind of figure out. Does this patient have some weird thing? Like, do they have a history of angioedema? Do they take a ACE inhibitor? Probably not in a 28-year-old, but maybe. Are they having an allergic reaction? What else could be going on? What are you going to do to treat the patient? How do you treat stridor? Okay. Yeah, so racemic epi-neb would probably be the first thing you would go to. If that doesn't help it, oxygen supplementation, trying to again talk to the patient, see, does it look like they're swelling anywhere? Talking to people who, if he got a block, what was your visualization? Was it easy? Was it difficult? That kind of thing.
Is there any role for like non-invasive positive pressure ventilation? Or is that just like a Band-Aid or something that's...
I don't think it's unreasonable. I think, again, it's probably situation dependent on what's happening. If it seems like it's just they need a little bit of support to keep the cords open or kind of get through that spasmic period while the swelling's kind of going down, maybe following the neb, I don't think it's unreasonable, but I don't think that it's going to be if they keep having stridor, they may have to be reintubated for a period of time. How could you make a definitive diagnosis? Yeah, you could call ENT to look. I think that's probably not going to go well in a really anxious patient who's short of breath, but in theory, you could do that.
Like a lateral neck film.
Yeah, you can get a lateral neck film. Can't really see a whole lot with ultrasound, but you could try to look with ultrasound. So, I think that's all right. That's it. Questions about stuff that's come up in the PACU? I think most of you guys have been in the PACU already. Any issues that you see over and over again?
Hypotension?
Yeah.
Yeah, hypotension, one of the more common.
9 out of 10 pain, like the sleeping patient.
Yeah, so that comes up all the time, right?
That's like the most common call.
Yeah, so what do you say when someone calls you and says, patient has 9 out of 10 pain, but but only when I wake them up to ask them if they're having pain?
Stop asking them.
Okay, so yeah. Do you really care what happens if they're sleeping most of the time? Probably not.
Yeah, usually. And I guess a lot of times those are the patients that have a chronic pain history.
Right, so that's another really important thing. What, if you're around, what is your baseline pain? If their baseline pain is a 6 and now it's a 9, well, that's, you just had a surgery. That's not unexpected.
Yeah.
So again, kind of that expectations, figuring out what the 9 is in relation to. And a lot of times the nurses are just wondering, can I send the patient to the floor?
It took me a while to realize, like, why they're all calling me about this all the time.
The PACU nurses are pretty good. And, I usually respond, like, if you're comfortable with it, I'm okay. And they're like, oh, yeah, I'm fine. It's fine. So it's just they want that. They have to be able to say, if it's above a certain level, they have to be able to write down that they ran it by somebody. So I think using them, like when you're in the ICU, like the ICU nurses are very knowledgeable. They will give you a lot of information. If you use them, they're very helpful. Same thing in the PACU. And as you get to know them, like certain ones will call more frequently, but the ones that don't call very much like you kind of have a sense of, okay, this is a real thing. I need to go check it out.
Yeah, I guess I just had a lot of patients that were like sleeping, like no hypertension, no tachycardia, but they were like really in pain, and I was like, could that possibly coexist? Like having really bad pain and being